Good morning from the University of Michigan in Ann Arbor. My name is Salim Hayek, and I'm both honored and excited to present to you about SuPAR and kidney disease, focusing specifically on reconciling the epidemiologic observations on SuPAR and underlying mechanisms. Here are my disclosures. I'm a member of the Scientific Advisory Board of Walden Biosciences, formerly known as TRISAC. In a few words, SuPAR represents the next breakthrough in our understanding of the link between the immune system and kidney disease. It is a potent signaling glycoprotein with diverse biological functions and is now being explored as a therapeutic target in kidney disease. Most relevant to this symposium is that SuPAR levels are very high in patients with diabetes and the major determinant of its complication. We and others have made tremendous headway in the past 5 years in our understanding of the role of SuPAR in kidney disease with a series of very high impact publications, which have led to SuPAR being highlighted by the American Society of Nephrology as a milestone discovery. As a quick primer, SuPAR is a soluble form of the urokinase plasminogen activated receptor, a 60 kilodalton 3-domain GPI anchored glycoprotein with linker regions cleaved by uPA and other proteases, leading to its existence in circulations in multiple different forms, noted here on the panel to the right. uPAR is expressed in various organs at low levels, but most strongly in the bone marrow and immune system. The circulating form, SuPAR, originates mainly from immune cells. SuPAR was initially proposed to be the elusive circulating factor for focal segmental glomerulosclerosis, which is a disease characterized by acute, massive proteinuria and chronically collapse of the glomerulus. The mechanisms for SuPAR's action are thought to occur through the activation of alpha V beta 3 integrin signaling, through which pathologic activation by SuPAR leads to cytoskeletal rearrangement of podocytes and their effacement with subsequent proteinuria. In this study, alpha V beta 3 integrin was shown to be highly dependent on uPAR. Dr. Reiser's group used immunostaining of glomeruli in both wild type and uPAR knockout mice, examining specifically AP5 binding. AP5 is an antibody that recognizes the N-terminal epitope of beta 3 integrin and is only accessible when the integrin is in its active conformation. Sympodocin here in red is a marker of podocyte. And LPS, a treatment known to cause food process effacement and proteinuria, was used in these podocytes. Now note that the increased AP5 activation highlighted in green when podocytes are exposed to LPS compared to uPAR knockout, in which AP5 activation is heavily dampened, suggesting that, again, uPAR is an important component of AP5 activation or integrin activation when exposed to LPS. And LPS in uPAR knockout mice does not cause podocyte effacement, as noted here, but injective vector expressing uPAR treat with LPS and voila, there's podocyte effacement and significant proteinuria. Both overexpression of SuPAR and injection of recombinant SuPAR in mice, as seen here, leads to dramatic increases in proteinuria. However, the role of SuPAR in kidney disease clearly extends beyond FSGS. In this study of 3,500 patients with cardiovascular disease who were followed for over 10 years, increasing SuPAR levels, notably above 3,000 picograms per milliliter, were associated with a steeper decline in kidney function. The highest SuPAR quartile had a 20% decrease in eGFR at 5 years, compared to only 7% in patients with SuPAR less than 3,000 picograms per milliliter. And when examining incidence CKD as the outcome, 40% of patients with SuPAR above 4,000 picograms per milliliter had CKD at 5 years, while less than 10% in those with SuPAR levels less than 3,000 picograms per milliliter. And in sensitivity analyses, this association was independent of the presence of diabetes or race. These findings have now been replicated across various patient groups, ethnicity, and disease subtypes, placing SuPAR as a universal risk factor for kidney disease and its progression. CKD, or chronic kidney disease, is a very simple word for, however, a very heterogeneous disease process. FSGS, for example, is a dramatically different disease than the slow and progressive kidney dysfunction noted in patients with cardiovascular disease or diabetes. So how do we reconcile the epidemiologic observations related to SuPAR and these pathophysiologic mechanisms? The answer in biological systems is never a simple one. Here we'll break down the major determinants of the association between SuPAR and kidney disease, starting off first by examining SuPAR levels. While it is obvious to state that higher SuPAR levels equate to higher risk, there are important nuances to consider. The most important is how SuPAR is measured. There are dramatic differences in levels between different SuPAR assays. For example, amongst the immunoassays, levels by the suPARnostic assay are on average 40% higher than quantiCOUNT, and they correlate with a correlation index of 0.753. Now, correlation between proteomics platforms and immunoassays are dismal, ranging from 0.2 to 0.5, suggesting that truly findings from proteomics platforms should not be used to make inferences regarding SuPAR. Now, the reason behind the differences between assays is an area of investigation, but it's likely related to the differential detection of these different assays of SuPAR isoforms, which we'll talk about next. Now, these differences between assays have important implications. So, for example, this study compared both SuPAR immunoassays in terms of their ability to differentiate between FSGS and non-FSGS glomerulopathy. The relative difference in levels between FSGS and other glomerulopathy was much larger when measured using the suPARnostic assay, or assay 1, than when measured the quantiCOUNT assay, assay B, as exemplified by these red arrows. And that translates to an area under the curve for differentiating between FSGS and non-FSGS that is truly dramatically different. For example, for the suPARnostic assay, the area on the curve was 0.4946, which was much larger than the 0.763 for the quantiCOUNT assay. So very important for you to check the assay that was used when interpreting findings related to SuPAR. Next, the phenotypic differences between these disease states attributed to SuPAR are likely related to the predominant circulating SuPAR isoform. I've shown you earlier that SuPAR exists in circulation in different forms due to differential cleavage. uPAR is cleaved at the GPI anchor to form the full-length SuPAR, which can also be cleaved at the different domains to form the shorter and larger isoforms. Now, these forms have major differences in biologic activity. For example, after overexpressing full-length SuPAR for about 16 weeks, only 30% of the mice develop proteinuria. Conversely, when expressing the D1, D2 isoform, for only 10 weeks, 80% of the mice develop proteinuria, which implies that the degree of proteinuria is highly dependent on the isoform being overexpressed. Not only do the isoform matter, but the duration of exposure to high SuPAR levels matter. In this study, SuPAR was overexpressed in the liver for only 6 weeks and at relatively low levels. There was no increase in proteinuria. There are many, many issues in this study, but one that I want to highlight here was that proteinuria was measured only after 6 weeks after SuPAR overexpression. While we've shown earlier that at least 16 weeks is required to have 30% of mice expressing having proteinuria for the full length and 10 weeks for the D1, D2 isoform. Now, lastly, prolonged exposure to high SuPAR levels are likely to lead to kidney disease. However, we've shown that the presence of other risk factors or injury dramatically exacerbates that effect. In a translational study incorporating both epidemiologic and experimental approaches, we sought to understand whether the penetrance of the genetic risk factor of APOL1 is dependent on SuPAR levels. And essentially, we've confirmed that finding in the African-American subset of the Emory Cardiovascular Biobank with patients who've had high-risk ApoL1 genotype, but low SuPAR levels, having very similar rates of decline to the low-risk ApoL1 genotype here in blue. While patients with both high-risk ApoL1 and high SuPAR level having a much faster decline. And these epidemiologic observations were corroborated with experimental models using transgenic mice, in which expression of ApoL1 variants led to proteinuria in wild-type mice, but not in the uPAR knockout mice, suggesting that, again, uPAR is an essential component of the pathophysiology of CKD related to ApoL1. And we've examined the incidence specifically of acute kidney injury linked to SuPAR in various clinical settings, including coronary angiography, cardiac surgery, critically ill patients, and patients with COVID-19 in large cohort sizes with various incidences of AKI. AKI in most of these studies was defined as a 0.3 milligrams per deciliter increase in, or 50% increase in creatinine. And in all four clinical scenarios, pre-injury SuPAR levels was associated with a stepwise increase in the incidence of AKI, very minimally attenuated after adjusting for clinical characteristics, baseline kidney function and inflammation, such as CRP, or other characteristics for each cohort. So for example, contrast volume or bypass time. And these are, again, are typically in Model 3. Model 2 includes clinical characteristics and inflammatory markers. And the effect was most pronounced in patients with COVID-19 who have very high SuPAR levels, above that of patients with cardiovascular disease or those with non-COVID-19 critical illness, as seen in the panel to the right. Now, to determine whether SuPAR is causally involved in exacerbating acute kidney injury, we used a mouse model of contrast-induced nephropathy in which we injected wild-type mice and SuPAR overexpressing transgenic mice through the peritoneum with iohexol. Half of these mice were pre-treated with anti-SuPAR. And what we found was that SuPAR overexpressing mice had significantly higher serum creatinine at 24 hours post-iohexol compared to wild type. Most importantly, pre-treatment of SuPAR overexpressing mice with anti-uPAR dramatically reduced the severity of AKI compared to transgenics who did not receive anti-uPAR, suggesting again that SuPAR could be a viable therapeutic target for the prevention of AKI. You can see here the histopathologic differences that are dramatic. SuPAR transgenic mice not exposed to iohexol appeared not to have significant abnormalities on histopathology. Now, administer iohexol and you can see extensive vacuolization of the proximal tubules, and that is abrogated by the pre-treatment with a uPAR antibody. Now, to try to understand the potential mechanisms involved, we analyzed the oxygen consumption rate of HK2 cells exposed to recombinant SuPAR with and without treatment with the uPAR antibodies. HK2 cells are cultured proximal tubular cells, and it has already been established that one of the mechanisms of AKI is thought to occur through alterations in mitochondrial respiration. And what we found here is that truly exposure to recombinant SuPAR led to dramatic increases in oxygen consumption rate. And that effect was abrogated with the addition of anti-uPAR. Similarly, when measuring the production of reactive oxygen species using mitosocs, you can see here that cells that are exposed to recombinant SuPAR are highlighted again in red using mitosocs, which implies significant generation of superoxide. Again, pre-treatment in vitro, again, of these cells with anti-uPAR abrogates that effect that looks very much similar to control. However, this effect doesn't occur on podocytes, which implies that SuPAR may be acting through very different mechanisms depending on the cell types, leading to both proteinuric and non-proteinuric kidney disease. And this is consistent with our observations that while half of the patients with significant proteinuria tend to have high SuPAR levels, nearly half of those without proteinuria had significantly high SuPAR levels. So while there's a correlation between SuPAR and proteinuria, the association between SuPAR and kidney disease is completely independent of the occurrence of proteinuria. Other groups have shown that targeting SuPAR is a viable strategy for the treatment of kidney disease. So in this experimental study of streptozotocin-induced diabetic nephropathy, uPARant, a small peptide that inhibits uPAR binding to formal peptide receptors, decreased the overall level and activated form of alpha V beta 3 integrins in the kidneys of mice, along with notable improvements in urine creatinine and urine albumin to creatinine ratio. This was the first study targeting SuPAR specifically in a model of diabetic nephropathy. So in summary, the epidemiologic evidence truly suggests that SuPAR is a global risk factor for kidney disease. And that relationship is a complex one that depends on levels, isoforms, duration of exposure, and comorbidities. The mechanism is also complex and goes beyond just podocytes. And we've recently shown that tubules are affected. Now, the exact mechanism is unknown, and again, is likely multifactorial and involves these different comorbidities. So we're still working on identifying specific mechanism. However, given the extensive both epidemiologic and experimental evidence, clinical trials are needed at this point to assess SuPAR's potential as a therapeutic target for kidney disease. And that is our major work for the years to come. So finally, I would like to acknowledge our incredible team at the University of Michigan and our collaborators across the world who made this research quite a fun adventure. And I thank you for inviting me again to give this talk, and I'm happy to entertain questions.